reduce the burden of cancer in South Texas through cancer research, education of future scientists, clinicians, and prevention programs focused on the needs of our South Texas population. And as mentioned previously, the Mays Cancer Center has an office of community outreach and engagement, and our team is responsible for monitoring and evaluating the South Texas cancer burdens. That means we keep track of the different cancers that we're seeing in South Texas, and we engage with our different communities. We inform our leadership about what we're hearing from our South Texas community about their needs and how this can influence future research that is being done by our researchers here at the Cancer Center. And that's why hearing from you and this PCORI project is so important to us. Overall, the purpose of Creando Conexiones project is to ensure that the South Texas survivors and caregivers have an active voice and are contributing to our research at the Mays Cancer Center. We have been working towards this for the last year and a half by developing a cancer health research agenda that addresses the South Texas disproportionate cancers and identifies research priority areas identified by our South Texas cancer survivors and caregivers, and identifying the infrastructure needs that the Cancer Center should focus on to make sure that we are addressing these priorities. Before I introduce our speakers, though, I want to pause and express my gratitude on behalf of the team and towards the survivors and caregivers who have participated so far in this project. We're really grateful for the time that you've spent with us and sharing your thoughts. We want to thank each of them for sharing their experiences, their insight, and their important knowledge about cancer treatment and the cancer journey. I would also like to thank the Creando Conexiones Coalition. The coalition is made up of organizations, survivors, and caregivers who have been touched by one of our 3 cancers or are supporting these individuals and families. If you are interested in joining our coalition, you can reach out to our team, and you can also use our cell phone to visit or the QR code that you see in the middle of the screen here to let us know that you're interested in participating. So today we are pleased to have a great group of speakers that are going to help us explore the leading research priorities that were identified by this project. Talking with us today about cervical cancer's priorities, although she cannot join us, will be Dr. Coralia Vasquez Otero, Assistant Professor at UT San Antonio. She's a member of our coalition. She recently had to go into the hospital, so Dr. Jones will be addressing some of the concerns that she wanted to express in today's webinar. And Ludovina Hernandez is a cancer survivor and a member of our coalition representing the cervical cancer area. For liver cancer, we have Andrea Wilson Woods. She's the CEO of the Blue Faery and a member of the coalition. And Sharon Dixon is a caregiver. And for pediatric leukemia panelists, we have Jason Maceda. He's the CEO and also our coalition chair, and Melissa Hernandez, who's a caregiver. Before we explore these research priorities, I'm going to hand it back to Dr. Jones, who's going to walk us through a brief exercise to help us get grounded for our conversation today. We will, and then she'll also give a brief overview of the framework that we use to organize the priorities that were identified as part of this project. So Dr. Jones.
Thank you, Dr. Ramirez. And so what we wanted to do before we kind of jumped into the conversation today is we wanted to just give folks in the call or on the call just a few seconds to just reflect a little bit on, what perspectives you bring as you listen to the conversations that we're going to have. So this is just some posing questions. We're not necessarily going to ask you to share them, but it's just something for you to reflect upon for yourself. And those are, how might your training and experiences influence the way that you think about patient-centered care and research? We're posing this question to the group because we know that on the call today, we have survivors and caregivers, organizations that provide services and support for our cancer family or families that have been touched by cancer. We also have clinicians and researchers. And so everyone brings a unique perspective to the discussions that we're going to have today, and we just want you to reflect on that. And then, we won't spend too much time, but those are the two questions that we're asking you just to think about as we think about the conversations today. So on the next slide, one of the things we did, as Dr. Ramirez mentioned, all right, if we can go to one of the things that we did, as we developed this project, we knew that we were hearing a lot of really good information from our survivors, caregivers, clinicians, and researchers, as well as members of our coalition. There was so much information that was shared to us, and we wanted to make sure that when we discussed the findings of this project and as we developed this research agenda, we wanted to make sure that it was going to complement the national and the international conversations that were happening in the realm of survivorship care. And so we, look to the literature to determine, are there frameworks that we can use to really ground all of the different conversations and findings that we're discovering in this process. And so we landed on the Cancer Survivorship Care Quality Framework. And so this framework has, several different domains, and I will read through them. And as you will see, as we go through the rest of today's discussion, this is really how we organized a lot of the findings and the priorities that we will be focusing on in this agenda. So, it kind of goes from a very high level to a very individual level. And so really the framework touches on the perspectives of community and policy, healthcare delivery, the prevention and surveillance of recurrence and new cancers, the surveillance and management of the physical and psychosocial effects of a cancer diagnosis, as well as how do we go about health promotion and disease prevention, and also the surveillance and the management of chronic conditions. And so as we go on through today, these are the main domains that we'll be having a lot of these conversations around.
Great. So we'd like to go now to the first part. We'd like to share with you our first panel dealt with the issues of cervical cancer research. And they identified priorities based on the input of our cervical cancer survivors, our caregivers, our clinicians, and researchers. But before we go into these particular priorities, I wanted to share with you why cervical cancer is important for us to address. Cervical cancer is most frequently diagnosed in women between the ages of 35 and 44, with the average age being around 50. It rarely develops in young women younger than the age of 20, and yet many older women don't realize that they are still at risk of developing cervical cancer as they age. More than 20% of cervical cancers are found in women over 65. However, these cancers rarely occur in women who have been getting their regular tests for cervical cancer. Cervical cancer incidence and mortality rates have dropped by more than half since the 1970s, thanks to regular screening and early detection. But in the last decade, we've seen that these rates have been leveling off. Among women between the ages of 30 to 44, the cases have risen about 2% each year since 2012, while rates in younger women ages 20 to 24 have fallen by about 11% each year. And this is more than likely due to the new HPV vaccine that was rolled out during that time period. And here in South Texas, though, the rates of cervical cancer, for some reason, are higher compared to the rest of the state and the entire country. So first to talk about this will be Dr. Jones. She'll present the top 3 research priorities identified by our survivors, caregivers, clinicians, and researchers as it relates to cervical cancer. Dr. Jones?
Thank you, Dr. Ramirez. So if you really consider the domains that I went through on the previous slide, we don't have time to go through all of them today, but we did want to just focus on the top 3. And again, these were all identified, by the conversations we had. And so the top 3 domains that our survivors and caregivers identified as priorities were managing the physical effects of cervical cancer, the ways in which healthcare delivery occurs, and the recurrence and the development of new cancers. So we'll first take a look at the first one, right? The surveillance and the management of the physical effects. The leading priority that was identified here was, and the question that our survivors and caregivers, encouraged us to look at was, how can we effectively manage the physical effects of a cervical cancer diagnosis, everything from the time of treatment into survivorship? So more specifically, when we spoke to our survivors and caregivers and other stakeholders, they stated that, the research that we're doing in this space should really determine how we can effectively provide medical and treatment information, as well as resources about these treatments these treatments, so that our survivors and caregivers can make those informed decisions, not only about the treatment that they select, but also managing those short and long-term effects of the treatment. The second priority that was identified was healthcare delivery. Healthcare delivery. And here the idea again was, our stakeholders stated that we should really be looking into research that evaluates how we can effectively leverage navigators and community health workers and broader members of the healthcare team to help provide support to our survivors and caregivers. In this space, when we spoke to our survivors and caregivers, some of the conversations we had was that, most of the women that were going through this journey, were the ones that kind of the heads of they took care of the household, right? And so how can we make sure that we're supporting our families as they go through this journey? The third priority was studying the cervical cancer recurrence and the development of new cancers. So in this realm, when we spoke with our survivors and caregivers and general stakeholders, they stressed the importance of identifying more innovative ways to have these conversations so we can increase the screening and early detection of cervical cancers. One of the things that was really apparent when we had discussion groups and interviews with our survivors and caregivers was the passion they had to make sure that we can help intervene at younger ages with women of younger age so that they are more aware of what the signs and symptoms of cervical cancer are and the importance of getting screening, as well as ways that they can prevent the developments of cervical cancer. So as I mentioned earlier, our goal for today is really to present these top 3 priorities, but more importantly, we want to really hear from the audience and we want to get your perspectives on what you think might be missing or what research questions you yourself might have as we talk about these different priorities.
Well, now I'd like to ask Ms. Hernandez and Dr. Jones to tell us a little bit about what they heard in the group with regards to surveillance and management of the short and long-term effects of cervical cancer, and what was the #1 research priority among our stakeholders. So from your perspective, and we'll start with Ms. Hernandez first, can you help us understand more about this? What kinds of research questions do you believe we should be asking?
I'm in a unique position where cervical cancer survivor, but I'm also a community health worker, and in dealing with this cancer myself, the questions that I had when I was diagnosed was, how is all the whole procedure? I felt like I was not given the information that I needed to make a full decision as to what my treatment should be. And that was my main concern, and it had come in as a concern to the other people that were on the focus groups. Mm-hmm.
Great, thank you so much. Dr. Jones, do you want to share what Dr. Otero's perspective was?
Absolutely. So Dr. Otero is actually, her area of research is in cervical cancer screening as well as HPV vaccine uptake. But nonetheless, I think one of the things that she mentioned was that, it's an important question for us to consider because we really need to think about how, the story of a diagnosis doesn't end when the treatment does. And many of our survivors are experiencing a range of short and long-term effects of their treatment. And so it's something to consider. One of the things that Dr. Ortero mentioned was that from a research perspective, one of the biggest priorities is to understand how we can monitor and manage the effects in a coordinated and evidence-based way. And so what she mentioned was, one of the things that she's observed or heard from clinicians and survivors was, when we think about the chemotherapy related neuropathy and treatment induced early menopause, these are two areas that we're still learning about, and areas that have, long-term effects on during survivorship. She mentioned in some of the work that she does, Dr. Ortero, that survivors are often telling, clinicians and clinicians that they weren't fully aware of the long-term side effects when they started their treatments, and they didn't know what to expect. And many of them, if they had known earlier about the risk of early menopause or nerve pain, they might not have changed their treatment choice, but they would have been better prepared could they have planned for life after the treatment. So Dr. Otero wanted us, left some questions that she felt were important in this research phase. And two of those were, how can we better predict who will experience certain physical effects based on the treatments, exposures, and medical history? And how can we improve the informed decision-making process so that conversations about the side effects happen earlier, are clearer, and are given compassionately?
Wow, both of you have shared with us some very important perspectives on this topic. At the end of the day, the goal is to make survivorship not just about living longer, but living well with our cancer, with coordinated, evidence-based care that can help every survivor thrive after treatment. I look forward to hearing more about what others at the end of this forum to share your thoughts in terms of cervical cancer and where we should go. And then for the next priority, too, in cervical cancer, when you think about the ways healthcare delivery is provided, the priority was to engage patient navigators and community health workers more. How can we do this? And what kind of health outcomes do you believe we can address by first doing research in this area? So, Ms. Hernandez, will you share your thoughts with us?
So, as a community health worker, we would be able to, if we were to be integrated in the support system for patients, to provide that initial education and information that patients may need to make the decisions and feel more comfortable of what the process would be, and so that's very important, for anybody that's going through a traumatic experience like getting cervical cancer diagnosis.
Great. Thank you. Thank you so much. And Dr. Jones, you want to again present Dr. Otero's perspective?
Absolutely, yes.
Priority two?
And one of the things that Dr. Otero mentioned was that when you think about engaging patient navigators and community health workers, it's not just about, another layer of support, but it's really the idea that we're recognizing that it's not just about the delivery of healthcare, it's supporting the entire patient. For those of us who are in the space of research, Dr. Otero also mentioned that from a research perspective that she's learned that before a clinician can present a care plan, it's really, or a researcher can invite a patient to participate in a study, we have to first understand what the day-to-day realities are of our survivors and our caregivers. And so if we're trying to get, folks to be adherent to their treatment plans, or if we're trying to enroll them into a research study, we have to think about, what their day-to-day looks like, and how can we make sure that we're setting them up for success, and we're making it as easy as possible for them to participate in research studies. Another thing that was mentioned was just the importance of, language, right? And this idea of, having navigators and community health workers that are able to determine, can provide information in a way that's accessible, that our CHWs and our patient navigators are sometimes the best individuals to help encourage participation or adherence to a treatment plan, just because of the relationship that they're able to establish with these individuals. And then there was two questions that Dr. Otero had mentioned would be important when we think about this area of research. And one of them was more on the side of how do we do, research? And that was, a question we might want to look about is how, in this context, was how can we identify the best ways to integrate navigators and community health workers into cervical cancer prevention and survivorship teams, right? So how can we study that and improve that within a clinical setting? From an outcomes perspective, Dr. Orfetto mentioned that it might be nice to be able to look at how we measure the effect that having CHWs or navigators are along the cancer continuum.
Yeah, and one of the other things we might think of I know like in the breast cancer area, they use breast cancer survivors and trained also as community health workers and navigators because they can really speak from their own personal experience. So that's something else we might want to think about. So again, thank you both for sharing your perspectives on priority 2 within cervical cancer. Now for priority 3, studying cervical cancer recurrence and development of new cancers for survivors was identified as a priority because even though you're treated, other cancers always persist out there. So this meant that there should be a special focus on screening and early detection. Similarly, how can we do this? And how can we first conduct research to find best ways of increasing screening for our South Texas women in our community? So Dr. Jones, I'll go back to you first since Dr. Oteto's not here with us, and I think she was sharing some perspective.
Absolutely. And one of those was, the importance that we really think about the uniqueness of our South Texas population, and really thinking about how we can encourage South Texas women to get their screenings, or just be more aware of how they can go about preventing cervical cancer. She mentioned that one of the things that we heard from survivors and the work that we did as part of this project and the work that she does for her own research was that sometimes, our system doesn't always work in that way. And some women are told that, they don't need a pap test anymore because of their age or because they've had a hysterectomy. And even when they have a history of cancer. And so Dr. Orteta's perspective was, it might be helpful if we had some cancer survivor specific guidelines. It's just this idea that after their cervical cancer treatments, there's still a need to be more responsive and mindful of the development of other cancers. And then I think one other thing I would mention was, she mentioned that we could start by partnering with our local clinics to pilot home-based HPV tests so that women can get screened without missing work or finding childcare. So just, not only specific to our survivors, but also to our general population in South Texas.
Right, that flexibility is going to be so important and finding easier ways for that early detection. So, Adnan, as being a survivor and your own perspective of what is it that you think we need to focus on? What have been some of the barriers that you personally, through your work, have also encountered or seen among some of our patients?
Well, first of all, the main barrier has been having access to healthcare. It's a financial issue that people deal with, and also having being the breadwinner of the family, not having the time, and having so many other responsibilities that they encounter. Things like transportation to their medical appointments, and it's just an overwhelming situation for them, and it's a barrier. It's where they need support, for their physical ailments that they have, but also for mental and emotional issues that they're going through at the time. And that's where community health workers can come in and be that support system that maybe the medical providers do not have the time to do in a clinical setting.
Right. Yeah. And providing it in a language, as Dr. Jones mentioned, that's so important, right? Where they can feel comfortable and they can discuss with you and, or a community health worker, their concerns. So thank you.
Yes, because a lot of times, I'm sorry, a lot of times, patients are more, or our community they feel more comfortable in letting us community health workers know of things that they may not even share with their healthcare team.
Exactly. No, it's so important. So thank you both for sharing these important thoughts. We need to find better ways to make screening easier, more consistent, and most of all, respectful of the needs of our women in South Texas, especially those who, have been diagnosed with cancer, and making sure that they're coming in for follow-up care. So we'll be gathering, questions. So those of you, we encourage you to list in the Q&A if there's any particular questions that you feel we should focus on with regards to cervical cancer. Please feel free to incorporate that information. Okay. I think, so again, as Dr. Jones mentioned, we'll just focus on the first three. There's a lot of work to be done. Again, our team really identified a number of issues, but just to keep our webinar running smoothly, we'd now like to transfer over to liver cancer. Okay. So again, just a little bit of background on liver cancer. People often want to know what causes liver cancer. However, it's not often one single reason. Cirrhosis is a progressive disease that causes inflammation and scarring. The more we learn that many of the risk factors that are impacting our lifestyles are also impacting liver cancer. But cirrhosis is the most common underlying condition that causes liver cancer. But there are other reasons as well, such as our metabolic dysfunction associated with different kinds of liver development, which is called MASLD, formerly known as non-alcoholic liver disease. And some of the contributors to that are either viral hepatitis B or C or chronic excessive intake of alcohol. But one of the most common causes of liver cancer here in South Texas is that the rates, for some reason, again, are higher compared to the rest of the state and other parts of the country. And we believe that the leading contributing cause to this metabolic dysfunction or non-alcoholic fatty liver disease might be caused by obesity and other associated comorbidities. So first, Dr. Jones will go through the three top research topics identified by our group. Dr. Jones?
Yes, thank you. So when we think for liver cancer, when we spoke with our survivors and caregivers and our stakeholders, the top three domains that were identified as priorities were the health promotion and disease prevention, managing the physical effects of liver cancer diagnosis, as well as how we deliver healthcare. So we'll take a look at this first priority, the leading priority, and that was, the idea of looking at health promotion and disease prevention. So the leading research priority was the idea here was that we should enhance clinicians' knowledge and awareness of liver cancer. Importantly for us in South Texas, and not just for South Texas, but when we think about our area, really thinking about increasing providers' awareness of associations between fatty liver, hepatitis C, and with liver cancer, as well as how liver cancer symptoms, kind of manifest themselves, as well as ways that we can go about screening for liver cancer and tests that could help us maybe detect or monitor what liver cancer looks like or how it develops. The next priority was the surveillance and the management of the short and the long-term physical effects of a liver cancer diagnosis. Here, the priority was, it was recommended that research be conducted to test the effectiveness of informed decision-making models between the patient, the caregiver, the provider, and the larger care team. And we will definitely unpack this as we have our discussion. And the third priority was healthcare delivery, and the focus was on how we can effectively increase and improve the access to specialists that are working in the space of liver oncology or liver care.
Right. I mean, this area is so there's so little research in it. Just the other day, a friend called. They had a colleague from the Valley that was diagnosed with stage 4 liver cancer and was trying to get an appointment here at our cancer center. So again, it's out there. It's becoming diagnosed at a little bit higher rates, and we need to understand so much more about it. So to join us in our discussion in this area, including Dr. Jones, we have Ms. Dixon, which we're excited to hear from Sharon, and also Andrea Wilson-Wood. And I'm so sorry that I didn't give you the correct introduction, but she's the president and founder of Blue Faery. So again, Andrea, we're excited for you to be here. So first of all, we think about health promotion and disease prevention for liver cancer patients and survivors. And we'd like to hear from you. Can you expand what we mean by improving clinicians' awareness of liver cancer? And how can we conduct research to find the best ways of increasing clinician awareness? So Ms. Dixon, as a liver cancer caregiver, can you share with us your thoughts on this?
Yes, as a caregiver, one of the biggest things that I've learned is that awareness isn't just something that patients need, it's something our doctors and nurses need too. When my husband was going through liver cancer, we discovered that the clinicians that a patient sees the most, such as a primary care physician, ER staff, nurses, etc., may not be familiar with the symptoms of liver cancer that a specialist would instantly recognize. We also often had to remind them about his hep C and his cirrhosis and asked how something would affect it, if a medication was okay for him to take, etc. It made me realize that not every clinician is fully aware of the unique risk, symptoms, or long-term needs that liver cancer patients face. Improving clinician awareness to me means making sure that the people caring for our families really understand liver cancer, not just how to treat it, but how to prevent it in the first place, how to diagnose it, and how to help prevent reoccurrence. That includes talking openly about things like alcohol use, testing for hepatitis, the link between liver cancer and diabetes and obesity, and having recommended screenings. When clinicians start these conversations, it makes a huge difference for both patients and families. I think that research can help us figure out the best ways to make that happen. Maybe that means studying how to build liver cancer education into the regular medical training, or sending testing reminders and tools that help providers talk with patients about prevention and follow-up. It could even mean including caregivers like us in those studies, because we see firsthand what needs to be done and what isn't done, and where communication needs to and education need to be improved. When clinicians are more aware and better informed, then sorry, gotta have kitty cat. That families feel more supported and confident in navigating the life after cancer.
Thank you so much for sharing, Sharon. That's got a lot of good information there. So, Ms. Wilson Woods, can you share us your thoughts on this issue?
Yes, absolutely. And I apologize for not being on camera. My computer crashed yesterday, so it's been kind of a nightmare. But I'm here. In an audio way. When we talk about improving clinician awareness of liver cancer, we are really talking about helping doctors, nurses, and care teams better understand the unique risk and needs of people who are at risk for, or who have even survived liver cancer, because it often comes back, especially primary care physicians and community oncologists. Many clinicians, specifically oncologists, they're very comfortable with common cancers like breast or colon cancer. But liver cancer is far more complicated because it's often connected to a chronic hepatitis infection, whether that be B or C, alcohol use, metabolic disease, or obesity. As many hepatologists like to say, it's a disease within a disease. So raising awareness means making sure clinicians know what to look for, how to talk about prevention, how to connect patients with vaccinations, or even curative drugs if they have hep C, screenings, and follow-up care that will reduce the risk of developing new cancers. And it also means referring to experts such as a gastroenterologist or hepatologist when necessary. From a research standpoint, we can study how to do this best by first assessing what clinicians already know and what the gaps are. And to refer back to something Sharon said, I feel like that this needs to start in med school. Like, that's our best bet at beating cancer down the road. For example, are physicians routinely talking about hepatitis B vaccinations? Are they even testing the baby boomer population for hepatitis C? Are they aware of screening recommendations for people with cirrhosis or fatty liver disease? Or do they even know what fatty liver disease is? Are they running a metabolic panel during an annual exam? And we are still in the last 2 days of Liver Cancer Awareness Month. And I always say the number one thing you can do is to have your liver enzymes checked. It's one more blood test, and it's part of a metabolic panel. So research can test different approaches. We can use continuing education programs, electronic health record reminders, or what I love to see, of course, are community-based partnerships to see which methods actually improve provider knowledge and patient outcomes. Ultimately, the goal is to make liver cancer prevention part of routine care, because as deadly as it is, liver cancer is one of the most preventable cancers. So that means making sure that every clinician feels confident counseling patients about lifestyle behaviors like alcohol reduction, increasing physical activity, improving diet, and connecting them to screening or vaccination when appropriate. And by doing this, we not only help prevent new cancers, but also improve survivorship and overall quality of life for our patients.
Wow, that's amazing. That's a lot there, but so true. And it just shows us that, again, that importance of early detection we can provide better care and, longer and more quality of life if we can ensure that early detection. So thank you both for sharing that perspective. Now, with priority 2, we talked about informed decision making. So when we think about the way healthcare delivery is provided, and the priority was improving informed decision-making models between the patient and the caregiver, the provider, and the large care team, how can we do this better? And what kind of health outcomes do you believe we can address by first doing research in this area? So going back to Ms. Dixon, can you share your thoughts?
As a caregiver, I learned that making decisions in liver cancer care isn't just about understanding medical facts, it's about being part of the conversation. We struggled for months to get a diagnosis, but once we had it, it was like we'd been thrown on a runaway roller coaster. We were referred from one specialist to another, interventional radiologist, hepatologist, oncologist, and sometimes we didn't even get to speak directly with the doctor. I never felt like any of those specialists even knew us. Most of our updates came from the nurse or a message on my chart. It was confusing, and honestly, it was scary. We had so many questions. What stage is the cancer? What are the odds of survival? What will treatment really be like? But there wasn't always time or space to get clear answers. Many times, even when we had time to ask the questions, I still felt like we weren't even being heard. And as his cancer progressed, those gaps in communication became even harder. When we reached the point of needing hospice, no one had ever really explained what that meant, how it worked, what to expect. I just knew that my husband was getting weaker and I didn't know what to do to help. In fact, none of the specialists ever mentioned hospice. His GI saw that his liver couldn't handle the treatment any longer and he referred us to hospice. That lack of information made us feel lost, hopeless, and like none of them cared. That's why improving how we make decisions together, families, patients, and doctors, is so important. We need a system where families feel informed and supported at every step, where the doctors talk with us, not to us or at us, and answer the questions as they're walking out the door, where we can ask hard questions without feeling rushed or being told not to worry about it. If we did more research on this, on how to make it so those conversations were clearer, more compassionate, more honest, and more coordinated, I think we could change so much. Families could plan better, patients could make informed choices that align with their values, and maybe we could all carry a little more peace through the hardest parts of this journey. Because at the end of the day, communication isn't just part of care, it is care.
That's so true. That dialogue between the patient, the provider, and the other family members is so critical. Thank you so much for sharing, Ms. Dixon. Now, Ms. Wilson Woods, what are your perspective on informed decision making, and how can we really look at it from a research perspective?
When we look at liver cancer, one of the biggest challenges we see is that it's often diagnosed too late, and that's for a couple of reasons. Our livers don't have pain receptors, and so when you finally feel pain, it's usually because the liver is now so enlarged it's pushing on other organs. Um, Also, if you don't know that you have underlying liver disease, that's a problem as well. So there's not enough screening for liver disease. And then many times, and this is what breaks my heart, is there are so many people like Sharon's husband, Jimmy, who knew they had underlying liver disease, but were never told that it could lead to liver cancer. And so they were never put under surveillance. And that means you've got a late stage diagnosis, and patients or families are suddenly faced with complex, life changing decisions, but they don't have the full picture. Many of our participants share that they did not get clear information about what stage the cancer was. And in fact, often the word stage doesn't even come up. They didn't know what treatment options existed or what to expect as the disease progressed. And also that balance of the liver disease, the underlying liver disease, and the cancer, which can often be at odds with each other. And some of them even describe feelings of resignation from the care team, or even worse, bias from the care team that did not want to treat them because it was hopeless. So when we think about improving how healthcare is delivered, it has to start with communication. Research can help us test new ways to make sure that patients and caregivers truly understand what's happening, and also they feel part of every decision. And that means using trained patient educators, sometimes called nurse navigators, creating clearer educational materials. Blue Faery has fantastic patient resource guides that are free and have been shipped worldwide in over 700 treatment centers in the US, or even building tools that help families weigh their treatment options together with the doctors, not after the fact. Sharon alluded to this too. There has to be improved coordination across a care team. Adults with liver cancer often have to coordinate their own care among different specialists. We're talking surgeons, oncologists, hepatologists, gastroenterologists, interventional radiologists, and that can be completely overwhelming for anyone. And research shows that models of coordinated care can help reduce confusion, improve satisfaction, and ensure patients aren't left to navigate the system alone. I often compare it to a swim team versus a football team. For me, swimming is really a solo sport, even if you're on a quote swim team, even if you do a relay in the Olympics, you're still in your own lane doing your specialty. Whereas a football team, there has to be, and I know you guys like football in Texas, there has to be communication. You can have the best quarterback in the world and they can still lose the Super Bowl because of the lack of communication among the team. So ultimately, by focusing on these communication and coordination gaps, we can improve outcomes that matter most to patients, like trust in their providers, understanding of their care options, smoother transitions between specialists, and most importantly, having a really good quality of life. When patients and caregivers are informed, supported, and heard, it doesn't just improve satisfaction, it also leads to earlier detection, stronger adherence to treatment, and most importantly, better survival rates.
Great. No, both of you have just provided some wonderful information, and I think for this, we're going to maybe just focus on the first two because, based on some of the comments that you just shared with us, we really talk about the importance of specialized care, right? And the coordination of that communications between the two. So thank you for those excellent points, and lots to think about here. And it looks like it's going to be a lot of research on the healthcare system. How can we create, right, a system where there can be better early detection, and then better communications between the providers and the caregivers, and then thirdly, the coordination of if all of these different specialists are brought in, how to make and I've seen it personally happen. My own father had liver cancer, so trying to communicate to one doctor to the other to make sure they were all on the same page really took someone who could find the time and invest in that. So thank you. Thank you for those tips and great information. And again, to our audience, please put in the Q&A any thoughts or questions that you might have. We'd really like to hear from you. Now we're going to go ahead and transfer over to our pediatric leukemia priorities. And just a little bit of information. I'm going to maybe jump to Dr. Jones on sharing what the priorities were for our pediatric leukemia research.
Absolutely. And so pediatric leukemia is actually one of our disproportionate cancers, and we have some of the highest rates of pediatric leukemia in South Texas compared to the rest of the state and the country. There's even regional differences within South Texas. Our areas around Laredo and Eagle Pass have the highest rates of pediatric leukemia compared to the rest of the country and the state. And so, with our coalition, we've been able to really get the perspectives of what are some of the leading questions that our communities and our families have as it relates to pediatric leukemia and the different types of pediatric leukemia. So when we spoke with our stakeholders in this realm, again, the top three priorities were the first one was the surveillance and the management of the physical effects, as well as the psychosocial effects of a pediatric of a leukemia diagnosis, and then going through that process. Those are the top two priorities. The third one was health promotion and disease prevention. So if we take a look at the first one, managing the short and the long-term effects of the physical effects of pediatric leukemia, the leading research priority that we heard was really to identify effective approaches to managing the symptoms and the side effects. And this can be achieved by possibly tailoring treatments based off of the specific profile and the genetic profile of our patients to help minimize the physical side effects. The next priority was managing the short and the long-term psychosocial effects of pediatric leukemia diagnosis. For this priority, one of the recommendations that we've received from our survivors and caregivers, as well as our clinicians and researchers, was that we identify effective approaches to help our survivors and caregivers really cope with the trauma, the grief, and the stress that is caused by a diagnosis and treatment. And the third priority was health promotion and disease prevention. And specifically in this realm, one of the areas that the priority was that we look to see how we can improve and increase awareness and the dissemination of survivorship guidelines. So we know that, this is one of the areas where we've made great strides in survivorship. And so we have our young pediatric leukemia survivors who are going into adulthood, and how can we make sure that we're providing good, guidelines for the care teams that are providing care for these individuals, as well as making sure that we are doing it not in a silo, right? So there's a ton of recommendations that exist, and so how can we go about really harmonizing all of these different recommendations and making it easier for our survivors and their caregivers to really help with the adherence to routine care as they go through their survivorship. And so I'll go ahead and hand it over to you, Dr. Ramirez.
Thank you. Thank you so much. So with us this afternoon are Jason and Melissa, who are going to share with us, and clarify what do we mean about managing the short and long-term physical effects of pediatric leukemia. Can you expand on what this means, and how can we conduct research to find best ways for improving clinician awareness on these issues? So we'll go to Melissa first. And thank you for your patience with, the dialogue in all of these cancers are just so important to all of us. So thank you.
Yeah, so when Ollie is my son, when Ollie was diagnosed with leukemia, the biggest challenge that we faced right out of the gate was not only just waiting forever for the doctors to actually tell us something, because I felt they were gatekeeping, but also because we had to choose right away what kind of port he was going to have and what kind of access he was going to have to get placed, and we didn't know, and we didn't know how to we didn't know what questions to ask or what we needed to do to be more informed. We were just told, hey, these are the options, this is what I think is best for your son, which I felt strongly about, because how do they know what's best for my son, right? He's my son, and I didn't know how to be informed in the they gave us like an hour to make a choice. I didn't know. And so I just went with whatever the doctor said to do. And so we were trying to understand all the physical effects of treatment, and not what's going to happen like right now, but in the future, when Ollie's 13 and going through puberty, like what is going to change then between between his treatments and what effects that they had then, like now what is it going to do? And this is not something that's temporary, it's something that even though he finished treatment, it's something that's going to be forever. And so we're thinking long term, like we didn't know to ask about his heart, to ask about his lungs, like we didn't know any of that. And so one of the we just really felt that it's a constant like learning curve for us as a team, my husband and I, and we just always felt exhausted trying to figure out what to say, what to ask, and we just didn't know. And so I think that it's important to have awareness, and to know it would have been really nice to have that maybe patient advocate in there with us to kind of like go over the terms, go over like what we're missing and what we don't know to ask, because what you don't know, you don't know.
Yeah.
And so that's kind of what we were going for. And it's really important that we focus on understanding the treatments and the way that they're designed for adults, but they're for our children, right? And
Right.
so I think that was something that was really important.
So Melissa, how old was Ollie when he was diagnosed, and how old is he now?
My son was diagnosed at 18 months old, and now he just rang the bell and finished treatment. Thank you,
That's
Jason.
awesome.
And so he's 4 now. He just turned 4.
Wonderful, wonderful. No, well, thank you for sharing your own personal story and most of all the things and challenges that you have faced. And Jason, as you lead an organization that's really focusing on pediatric leukemia, what are your thoughts in terms of the short and long-term effects, and what do you feel we need to focus on?
Yeah, absolutely. But I do want to start with those positives. Like Ollie did ring his bell, at 4 years old, little Jaime at 7, and Tristan at 5 years old. So we are seeing some success, although there are some tragedies that have happened. So when talking about that, and Melissa, if you're okay with me sharing a little more, it's like,
yeah, of course,
focus on, long-term and short-term goals, but it's also having understanding what the insurance provides. Because one thing Ollie went through was he had to get his port, another surgery for his port, because the insurance wasn't read correctly and they didn't cover one of them, and he had to go through that pain again. So if there was a patient advocate available, they can help navigate through that to make sure that the doctors are doing the right thing. So this was a failure on the medical side of things, that was completely out of Melissa's hands in the family. So it's important to talk about these stories, because it happens more frequently than not. So, and we're really talking about 2 interconnected goals: is helping children survive through their cancer and protecting the long-term and quality of life. The treatments today have come a long way, but many of the therapies are more precise and effective than ever, although, they come with issues, because their toxicity can be very significant, because it's adult medications abused on these children. And with the developing bodies, that means that the treatment, although can save their lives, can also cause lasting effects that might not appear until years later. Very much like Melissa was talking about, like what are the possibilities of, a few years later of what her child can encounter. For short-term effects for the families that we see very often is fatigue, pain, restlessness, muscle aches during treatment. The long-term effects can be complex, things like heart, lung, very much like she was saying, kidney, delayed growth, speech, or in some cases, fertility challenges later in life. So for survivors and caregivers, these are conversations that are extremely important, both for short-term and long-term effects. And often they don't happen early enough to have enough detail. And that's where improving clinician awareness is extremely critical. So on the research standpoint, most of the important things that we can do to study is therapies on therapies originally designed for adults that often affect children differently, and how they're tolerated, how dosing should be adjusted, and high-risk strategies can be prevented from long-term harm. For example, controlling blood pressure, and whenever they receive anthracyclines or chest radiation to help reduce future problems, and incorporating fertility prevention for even like on the female side, in discussions about diagnosis before treatment begins, to ensure that families have like choices, because a lot of their children, right? So we want to have choices for these children when they get to adult age, or even young adults. And to improve the clinician awareness and research and focus, there's 3 areas, which is development of evidence-based guidelines to help recognize and monitor those effects across the whole care of that family. And that's one of the things that the families that I encounter a lot is they're not getting that information because the clinicians are not aware of it either. So as Dr. Jones was talking about, it's still kind of an underfunded, underserved area for pediatric cancer. So these are the things that we need to focus on: embedding survivorship education into pediatric oncology training so that providers can confidently discuss long-term and preventative care with families. And then the third one is partnering up with caregivers and survivors, very much like other cancers that we're talking about, to design studies to reflect the lived experience on how the discussions and even the central venous catheters and symptom management that can affect the child's treatment for long and short term. So these are crucial conversations to have that can be improved with the research that we're doing today.
That's great, Jason. No, thank you. Those are really important questions that we need to address. And again, I encourage our audience to any other thoughts or questions that come to your mind to please put in the Q&A section. Now, to address priority 2, it focuses on managing the psychological effects of pediatric cancer. Same as the question before. Can you expand on what you mean by this, and how can we conduct research to find better ways on improving clinician awareness about these effects? So, Melissa?
I'm sorry, I lost where I was.
Right,
We were on priority 2, right?
That's correct.
So when we talk about psychological effects and of pediatric leukemia, we're talking about the emotional and social toll that the diagnosis can have. And this isn't like, I don't know for sure, but I feel like there are many of us as caregivers and as families that go through a PTSD diagnosis after the fact of your child getting diagnosed with cancer itself. And so I feel like that's important to mention on here too. And it's not just our children, but it's the entire family, trying to manage the anxiety and the depression from everyone, my 7-year-old, my husband, myself. And it's really, it takes a big toll on the whole family. So it almost feels like it wasn't just Ollie that was diagnosed with cancer. Like we all have it, like we're all doing it. And so, and our kids are trying to make a sense of something far bigger than they can even comprehend. One of Zoe's first questions, that's my daughter, one of Zoe's first questions, she was about to turn 5, and I told her about Ollie's diagnosis, and she was like, so he's not coming home yet? And I was like, no, not yet, he's still in the hospital. And she said, well, what is cancer? And like it had me thinking, like, oh my gosh, she's 4. She doesn't even know what cancer is. Something that we as adults can comprehend because we've been there at some point. There's somebody that made a quote that says, like, if you live long enough, you'll get cancer, right? And so eventually us as adults, we all kind of have some kind of experience with it. But a 4-year-old, let alone an 18-month-old, how do you explain to him about his cancer and what he's about to go through? And so it's they can't emotionally or cognitively process, hey, you have cancer. Like, they can't do that. And so then it becomes the job of my husband and myself to advocate for that and to try to teach them. And now Zoe can understand. So now it's her job to advocate too. And it's like when my children are talking in the future as adults, they're going to be talking about how they had been emotionally traumatized, but not by their parents, by cancer. Cancer emotionally traumatized them. And so we need to be able to shape how our kids think and feel and grow long after his treatment is over.
Well, Melissa, you've identified several important aspects and the impact of this diagnosis on the entire family, right? Because usually you're young, your children are diagnosed at a younger age. That's in your prime of your life of working, taking your other children to school and so forth, and just managing the schedules and the time that you have to spend in the hospital. All of those things really requires almost an army of people, right, to help you, surrounded by family to get through this. So there's a lot of different issues.
And I feel like in the in my husband's culture, like, they don't talk about mental health. They don't take it seriously. It's kind of like you just kind of kick it under the rug and kind of just keep going. And so it's been hard for him to like come out and, yeah, I do feel that does kind of hurt. That does kind of mess up my day, or and then the fact that he has to he always says, I have to be stronger for y'all because I can't talk to you about all these diagnoses because then you cry.
Right.
And
right.
so he kind of has that like stigma going, and it's just like ingrained inside him. It's not like he wants to necessarily have that. It's just there.
Right.
So.
Oh, thank you so much. Jason, your perspective on psychosocial effects.
Yeah, well, I mean, to kind of jump on what she was saying in the Latino culture and cultura, like when you were growing up and raised, there's a comedian, George Lopez, that says, "Why are you crying?" Like one of the things that he skits about, but that's actually real. In the Latino community, they're like, "Hey, suck it up and move forward." And guess what? If you're the head of the household, you can't have emotions. You got to just take care of your family. So more often than not, I encounter men, parents, fathers I'm sitting in an office and they just break down when I close the door. Like, I'm not sure what to do because they don't know. It's still taboo to talk about mental health. And I always emphasize it's okay not to be okay. And that's why we exist here. In managing the psychosocial effects of pediatric leukemia, it's referring to the emotional and social development challenge from children and their families. That includes the parents, right? Often the beginning diagnosis extended to survivorship for a child leukemia diagnosis and early trauma. Their coping skills are still developing to experience the hospital stays. Procedures, uncertainty can deeply affect how they understand the illness, especially with the siblings, like Melissa was saying. So one of the things that I'm encountering from kids that aren't ringing their bell, the parents are coming to me and saying, what do I say? Because my daughter and my son are saying, when am I going to ring the bell?
Right.
There's the guilt of survivorship for some of the kids that understand, and there's the other ones that feel like they're left behind. So those are the things that we encounter on a regular day, like when we're talking to our families. These psychosocial effects can shape the emotions, emotionally, and the motor development skills. That's also important to include the pediatric psychologist for child life specialists, the behavioral therapists, and care teams to help the children express the fear, anxiety, and confusion in the age-appropriate ways to reassure the parents and the child of the developmental progress. I mean, and it's happening on a regular basis because we are seeing just in 2025, 300 children have been diagnosed with cancer in the city of San Antonio. So that's a lot for our city, no matter how large our city is. So, but all of this doesn't stop with the child. The caregivers profoundly impacted. They're navigating with fear, fatigue, financial strain. One of the reasons we exist here. The non-medical drivers of health is what we focus on. So we hear from so many parents that this is, while their child has had access to counseling, they never are asked how are they coping with it. So the points to a gap in our current model of psychosocial care, including caregiver counseling, is part of the care plan, not only as an option, but it should be as an add-on that can strengthen the family's resilience and well-being. Because ultimately, if the family's doing okay, they could focus on the child's healing while they're coping with it. So from the research perspective, we can improve clinicians' awareness by studying how the psychosocial effects are identified, documented, and managed across the cancer centers. For example, whether it's systematic screening or depression, anxiety, and family stress is being done, and how often are these screenings led to appropriate referrals and interventions. We could also conduct patient-centered comparative effective research, which can test the types of support such as family counseling, support groups, or school reintegration programs to lead the best outcomes for survivors and caregivers, which there's still a lack of in our community. And that's why this is so good about this research. So we have to consider the context. In South Texas, Latino communities, is often a stigma around mental health. So research explores how to reduce the stigma and normalize emotional well-being, but it starts with a conversation. So that's what we're having today, is having that conversation to relieve that, to get it out of being taboo, right, and ultimately improving the clinician awareness. And it's about training. It's about creating a care system that recognizes and respond the full emotional experience from both the child and their family, so they can survive and thrive during this diagnosis.
Yeah. Right on, Jason. You've shared a lot, both you and Melissa, that it's not just the patient that's been affected, but it's the entire family. We had a colleague who had two children and actually 3 children. One was diagnosed with pediatric leukemia and unfortunately did not survive, but the impact that it had on the entire family was really critical. And we helped come up with teams of people that would go and just give them some relief time in the hospital so that they could be with their other children. All of these things that, there are other kinds of support systems that are totally needed for our families. So thank you so much. And again, because of time, we're going to stick with just these 2 initial priorities, but I'd like to send it back to Dr. Jones to provide us with some input, and then we hopefully I don't see any questions yet coming in the Q&A. We hope people will feel that you can write some questions there to ask of our panelists.
Thank you, Dr. Ramirez, and thank you, everyone, all of the speakers today, for talking about giving your perspective on these research priorities. I think Dr. Ramirez and I had the privilege of really continue to have the privilege of leading this project. And, I will speak for myself when I say that it's a huge honor to be able to bring the voices and the perspectives of everyone who's been involved in this project back to our cancer center. Patient-centered research is something that we've done at the Cancer Center, but never to this extent, where we're truly asking South Texas survivors and caregivers and the folks that provide care to these individuals, how can we do better in this space? One of the things that I won't touch on it too much today, but there's been such a huge dialogue in itself, right? So overall, when we develop this research agenda and we publish it for the public, there's going to be over, oh my goodness, I think 45 different research priorities across these 3 cancers that clinicians and researchers and survivors and caregivers could get involved in so that we can do this work at our cancer center. And in order for us to do this, it's also important for us to think about how the cancer center is structured to support this type of work. And so we won't talk about that today, but there's an entire section within this research agenda that says how our own survivors and caregivers are recommending that we do this work. And so, I think as we kind of we're not done yet, but as we come to the end of this virtual forum, I just want to reiterate or stress, the idea that this entire agenda is being done for the betterment of South Texas, to make sure that we're doing research that is really going to mean something and impact the daily lives of our survivors and caregivers. And so one of the things that I wanted to just touch on briefly was, across all of our priorities, one of the things that was mentioned was the importance of really looking at the community level awareness of these 3 cancers, as well as having, policy that can help address these. And so I'll start with the first one, but from a policy perspective, what we heard from our survivors and caregivers, and I want to also just mention, like, these were open-ended conversations. They were truly guided by the perspectives and the lived experiences of our survivors and caregivers. And so and the journeys that they faced. And so from a policy perspective, it was recommended that we look at expanding Medicaid, enhancing community health worker use, and also improving healthcare access and affordability. And so that is something that can be done. Some of the recommendations that our survivors and caregivers gave themselves was to look at, how can we better advocate for greater use of community health workers? How can we expand Medicaid in Texas? How can we make sure that programs like CHIP and the Affordable Care Act are more inclusive of the kinds of treatment and care that is required when you get a cancer diagnosis? And then from a community perspective, again, I think one of the things that came out very loudly was, a lot of our survivors and caregivers who participated in our interviews and discussions, they wanted to just be able to contribute to the dialogue. They knew that, we can't, right now, there's not a cure for cancer, but if there's a way to make the journey a little bit easier for those that come after them, they wanted to do that. And that was their kind of main reason for even participating in our interviews and all of the series of the over 7 activities that we've kind of done over the last year and a half to get to this point. But increasing awareness about these cancers, even if it's as not simple, that might not be the best word, but just thinking about, like, what are the signs and symptoms? Like, what kinds of tests can we do? So that we can help, raise awareness. And if I see this in my significant other, if I see this in my child, if I know that I have a family history of this, how can I talk to my providers and get the care that's required, or so that I can help identify it early or prevent it? And so from a really big global perspective, as Dr. Ramirez mentioned, our work at the Cancer Center as part of our community outreach and engagement is really to bring these perspectives to our leadership to make sure that there's a way for us to address it. And so again, we definitely, I'm going to hand it back over to Dr. Ramirez, but I really hope that folks in this call will, continue to, ask questions and see how they can contribute to this agenda as well.
Thank you. Thank you so much, Dr. Jones. It's really critical, as we see here. It's so important. Your voice is critical. And we really want to thank the panelists for doing such an amazing job and having been participated in this session today and also throughout the year and giving us your feedback. I'd like to open it up to all our panelists. I didn't see any questions come in through the Q&A, but you yourselves, based on what you heard, are there questions that you feel that you want to ask one another, or get any additional clarification? So open your mics and just be open with us and share your thoughts.
So if you don't mind, it's not really a question, but I was invited to the Health Collaborative for Bell County's Community Health Leadership. Mm-hmm. I think for the work that you're doing, I think that needs to be sent over to this team here so they can have it, because they compiled all this research. But what I didn't see is a lot of what we're doing research on today, which mm-hmm. is involving the San Antonio community. So I think part of what we're doing needs to get to the Bexar County side of it so they can add us into their stats of how they're tracking the health and the needs of our community. One other thing, and you can stop me at any moment, because I tend to talk about, I think, issues that really need is what's going on right now. A lot of our families are going to be cut off of SNAP at November 1. And so we help supply some of these needs. But at the same time, because of the government shutting down for nonprofits, I did not get government funding, but it's affected the private sector. Currently, the nonprofit sector is talking about eliminating small nonprofits. I'm considered a small nonprofit, even though I have a big footprint. And so organizations that are in my space are not going to be getting the funding that they need. So this is a time for all of us to partner up and put our heads together to figure out how are we going to survive so we can be there for the mission that we serve for these people. So if anybody wants to reach out to me so we can get together to keep advocating to make sure that we don't get cut out of these funding. For those of y'all that are located in our area or serve the Bexar County and San Antonio, please connect with me. Let's talk about how we can do this, because I can't shut my doors. These families need to be taken care of, especially coming into what's coming across there, because we're talking about 16 million children across the United States. They're going to lose benefits. 8 million seniors, 22,000 active military soldiers, 1.2 million veterans that are on SNAP benefits. These are things that are happening in our community. And I think it's important to not just do the research we're doing, but come together as a collective to help kind of get through this wave of chaos that's coming our way. So sorry, I don't want to take too much.
Thank you, Jason. I think it's kind of the concern that we all have, and you voiced it very articulately. It's the importance of coming together until our community voices, raise a little higher to the attention that we can create change. And it's that education and advocacy that is so important throughout our communities. So I wanted to go back to Andrea. Any thoughts or questions that we may have left out?
I don't think so. I think just the biggest challenge is that the providers that need the most education are the hardest ones to get to the table. It's very easy at the liver meeting, which is coming up in a week here, or at ASCO's annual meeting, to meet experts who are already in the liver cancer space, or to even get them to attend CME events, which we collaborate on a lot of those. But then it's kind of like preaching to the choir. And so I feel like the biggest challenge is really getting down to that community level of community oncologists and primary care physicians, especially as MASH and MASLD is what they call it now, essentially fatty liver disease, is becoming one of the most commonly known causes of liver cancer. And so we have to get to people early and talk about lifestyle, and I hate the word diet. That's not really the best word. It's more permanent food changes.
Right. Yeah, permanent. And also, it's not just the individual behavior change that we need, but we need support from the individuals who are providing these foods, right? To also make the appropriate changes so that the food that we're purchasing is high quality, healthy foods.
Agree. That's a whole nother conversation. Right. The food industry.
Exactly. Yeah. Thank you. What about our caregivers? Sharon or Melissa, any thoughts that you feel that we didn't include or that we should think about?
I don't think so. But I mean, I agree with Andrea that the problem is to get it, what we were talking about, like with the liver, is to get it to the ones who need to hear it. Because she and I have preached this the same thing to lots of groups, but and usually, like she says, we're preaching to the choir, because we're talking to the specialist or talking to the families, and we just need to figure out how to get it to the people who need to hear it. Especially because while Jimmy's liver cancer was related to Hep C and was related to cirrhosis and alcohol use, I also lost a cousin who never drank a drop in her life, who hers was from fatty liver, but she never was told she had fatty liver. Nothing was ever mentioned. They discovered it when it was in a late stage, when they were taking her gallbladder out, that she had liver cancer. And, and she lived for like a year after that, because people just don't know. No one. She was. No one ever said it. She did have diabetes, and she was a chubby girl, but no one ever said anything. And I worry about that. And I preach it to my doctor to make sure with Jimmy and everything, and with Linda, that I'm tested, because I have diabetes and I'm getting older, and I'm not skinny, and so I worry about that, and because but people don't hear about it, and the doctors don't tell us what to do.
Right. And even those individuals, in my father's case, he didn't drink or smoke, and he went to the doctor on a regular basis every 6 months, and then all of a sudden, severe pain, and he's in the hospital, and that's finally when they diagnosed it. But it was difficult. But he was also a little on the heavy side, and so these are critical, factors, particularly in the demographics of our South Texas community that we need to inform. It's hard to be a regular exerciser, and things because of the heat, right? And so how to find better ways to get around it and still be able to get your exercise and get the appropriate foods that we need. So. Well, I can't thank you all enough. I'm with Dr. Jones. We're really thankful and grateful for the time you have spent with us and the knowledge that you have shared. We are going to try to make a difference. Research means there's got to be money there to be able to do the research and to create the changes. So, we will certainly share these, as Dr. Jones said, as widely as possible, because maybe if we can't do it here, maybe other groups can pick it up and pursue with that. So again, a very, very special thank you. So Dr. Jones, any thoughts on how, this webinar was recorded, might be available for those who were not able to join us?
Absolutely, yes. And before we go to those details, I'll hand it to Melissa. Go ahead, Melissa.
Oh, I'm so sorry.
No, it's okay. It's okay. I just had a couple of things. Number one, to touch back on what Jason was talking about, and I think Rebecca talked about it too, Ms. Jones. We really need to advocate for the caregivers and the families as a whole to have some kind of psychological care implanted into like the whole of the diagnosis, right? And I think that that's really important to mention again, because my husband and I have not had any psychological, or even my daughter, who has very high anxiety now, and literally has panic attacks, but I have not yet been able to get her the care that she needs, because I've been so caught up in caring for my son that my daughter fell under the radar. And so I think that it's really important to have those discussions about healthcare for the entire family as far as what we need therapeutically. And then secondly, I'd like to say it was really hard when Ollie was in the hospital, having to split the family up because Methodist does not allow children, understandably, under the age of 16 inside the hospital walls where brother was.
Right.
And so I think that we need to advocate to have a special room or something where caregivers and husbands and children and babies that are diagnosed can go and see their families, because I think that that's very important while you're in the hospital, to still be able to see big sister and still be able to play and still be able to, as much as possible, be a kid. And I saw a very lackluster effort for making sure that Ollie got to see his sister. He got to see her one time in the over a month that he was in the hospital, and that was it. And the rest of the time it was, oh well. And so I think that it's important to talk about how if our children are able to see each other, why I understand why we wouldn't be able to, right? Which is why I'm suggesting having a specialized area for it. It's immensely it improves the health of our children if they're able to kind of see their family. It makes a big impact.
Yeah, that separation is very, very detrimental. Yes, so being more inclusive and making sure that there's those family opportunities are critical. Thank you for sharing, Melissa. And Ludivina, anything that you think we left out that we need to focus on cervical cancer?
As a legal worker where I go, I'm an advocate for the HPV vaccine. And we're actually, yesterday we have a presentation at our community center where we brought an intern that talked about kidney disease and elaborated on a lot of other things. So we're coordinating with her to come in and give a presentation to her parish, and including the teens the teen group. So, because we need to start when they're young,
Exactly.
in order for it to stay healthy, and the parents are that way engaging the whole family, coming the parents, and it has to be a family effort. So that's where we're, just trying to make a dent on all of diabetes, high blood pressure, and kidney disease, which is prevalent in our community.
Yeah, no, so important, and to remind them that it's a 3-dose. It's not just 1 dose, and to get the repeated vaccinations. So thank you. All right, thank you so much.
Well,
Dr. Jones?
Yes,
Yeah.
thank you everyone for joining today. In terms of next steps, we will be finalizing the research agenda over the next month, and we will spend the next 3 to 4 months actually getting this out into the community, getting it out into the hands of folks, community members, our survivors and caregivers, our clinicians, everyone, so that they can kind of look to see what resonates with them. As part of the COE, we do a lot with connecting individuals with researchers. And so as you get your hands on this research agenda, if there's something that you want to address, you can certainly reach out to our team at the Cancer Center, and we can look to see how we can pair you up with researchers to start working on this stuff. But with that said, I just thank you all for giving us your time. Our panelists and speakers, thank you for being willing to share your perspectives with us today. So I hope everyone has a good afternoon.
Thank you all. Yes, and we continue to send our thoughts. Thank you.